And we are now live.
All right. Good morning. This is Senate Health and Welfare. It is April 13th, and we're looking at a variety of bills as we're trying to work on the House bills that have come to us. So we're starting out with H190, and there is a motion already made and seconded on H190, an act relating to removing residency requirements for Vermont's patient choice end-of-life laws. So, and after we deal with that, we'll be moving on to H222, H94, H171, and that will fill out our usual very busy day. All right, so H190, the motion was made and seconded. We postponed a day. We've actually postponed 2 days to consider the bill, and now discussion. Any discussion? So
You good, Senator?
please.
Thank you for the delay.
You're welcome. After much consternation on my part.
You're very welcome.
All right.
Okay, so we are ready for a vote on S190, and I will go first. Senator Gulick says yes. Senator Hardy? Yes. Senator Williams?
No,
Senator Weeks?
yes.
And Chair Lyons?
Yes.
The vote in committee is 4-1-0.
I'm happy to report. Yeah. Thank you all. That was it's an important change, I think, for people who are at end of life, literally. Okay, that's good. We have 5 minutes. So in our 5 minutes, Katie will be coming in, but Jeff, you are here. So, and also Katie's going to be bringing in an amendment that Senator Sears asked and had Tanya, Senator Wrightkowski, work with me on a proposal amendment. I also talked with that's so lovely.
Wow.
That's mom.
Oh,
Better get it.
That's your mom?
That's mom.
Go out into the hall and talk to mom.
Anyway, so we put together, there's an amendment that is based on some work in judiciary around the immunity. And so Katie will bring that in the process of working on the language that Representative Lalonde and Representative Whitman also asked to have, and we'll look at that and consider it. Then some, in addition to the immunity section, money for testing equipment was added in. So we'll be looking at that when it gets here, and I've asked Department of Health to look at that language. So we've got, it's not a complex amendment, but it's stuff that we have looked at so much. Oh, yeah, gone, yeah. All right, so when Katie comes in, we'll look at that, but Jeff Hochberg is here, and why don't you come up, and we're on H222. I don't think we've made any changes to it as yet, so your testimony as well.
Thank you, Madam Chair. For the record, my name is Jeff Hochberg. I'm the president of Vermont Retail Druggists. I'm also one of the managing partners of the Smile State Pharmacy Group. Just came in here real quickly to talk about H222. 2 points that I wanted to make sure the committee was aware of. The first being that Narcan, is going over the counter. So
Has that happened already?
the FDA has approved it.
Yeah.
Basically, what we're waiting on is the manufacturers to create new specific over-the-counter packaging, and that has to be just approved for final approval from the FDA. So once that happens, they're already advertising it on all their websites. I would expect it sometime in the very near future getting an actual start date. So I just wanted to bring that to the committee's attention as to whether or not there's a need to create statute around such one that's going to be widely available.
So I'm trying to, I know that that's in section 4, we have distribution of Narcan.
Can I ask a question real quick?
Yes.
What, so that to me seems like a real simple issue that's gonna be fixed quickly, but I have no idea how these mechanisms work. What do you think the timeline is? Is it like 6 months? Is it a year? I mean,
Well, I think all historical, data is thrown out the window because of how things have evolved since the pandemic and how quickly things turn around. This is a hot topic politically, both nationally and here. So I think that it's going to be very quick. I would say in less than that calendar year. I would expect actually probably by the summer. As everyone's revamping too for the distribution of COVID vaccines, for the upcoming seasonality of that. The anticipation is, I think, July for that to be available through traditional wholesale models. So I expect we'll hear something from Farmland more very soon.
Madam Chair, can I ask a question? So where in the bill are you specifically, what,
The whole, yes, it's
In section 4, if you look at page, I think page 5, 4 and 5 have language related to distribution of opioid antagonists. I'm not sure, I'm trying to see if there's specific language about, it says healthcare professional prescribes, dispenses, or distributes antagonists. So we'll have to ask like counsel. And then the other question is, are there other antagonists that are currently not over the counter? So does it serve to continue this, maintain that?
I guess, Madam Chair, I think it's through belt, as we say, belts and suspenders.
Totally.
There are so many things that could hold this up. I think Senator Gulick's question is a good one. I think that we should leave it in here because
Yeah,
if in case something happens, we want
Yeah.
to make sure.
well, that was
it's
the
available.
point, that there may be others, even though Narcan comes out, it's okay over OTC, but, so, well,
Exactly.
Yeah.
but this is helpful information for us.
We just don't want to limit it in any way, any
Yeah.
capacity, so that it is, we don't prohibit it from being available in every convenience store, gas station, whatever, as many places as we see.
Okay. Thank you.
So that was just the first topic. If there's any other questions on that?
Any other questions?
So the only other consideration that I wanted to bring to the committee was something that we see transpire every day. In the treatment programs, the buprenorphine in particular, there are economic barriers that we see play out, particularly when it comes to Department of Corrections and people that have left the system and that are transitioning into either from a treatment center and then hopefully getting a job and moving on. And there's usually a significant lag in insurance coverage. Whenever there's a lag in insurance coverage, particularly one that involves Medicaid, there's a disagreement between what's covered and what's not, and it creates a financial burden for patients. Medicaid requires brand name Suboxone, the films, as its preferred agent. Most other commercial carriers all cover the generic. The issue is that if someone is in the application process at the pharmacy level, we don't know when they're actually going to be covered for the Medicaid, but Medicaid does have it within its capacity to go retrospectively. So if a patient who's in that gap comes into the pharmacy needing their medication, knows that they are already applied for Medicaid, but hasn't received coverage quite yet, then the pharmacy has to advise the patient to purchase the brand name out of pocket, because that's the only way it will be reimbursed once coverage is obtained. Now, the difference between that pricing is the the brand name product costs about $9 a film as opposed to generic, it's $2. It's a substantial discount for generic. And this issue was raised, and I just want to make sure that there is a pathway that we talked about having the prior authorizations spread across the board. We need to make sure that there's some kind of coverage for those people in the gap, because we see this all the time.
So do you have suggestions for the language?
Don't, this is, it gets kind of too weedy with how everything else goes, but
Well,
apart from
yeah.
Medicaid requiring coverage on the generic for the first bills or coverage within the generic gap or in this coverage gap, something along those lines?
something, the timing of determination is also.
Correct.
So if you accelerated that, you wouldn't have to go through this. But so David actually asked to talk with me and eventually all of us about another section of the bill on the possession of 24 milligrams of the buprenorphine. So anyway, we'll be looking at that, and they're coming in, and then even you're welcome to come in and meet with me as long as our doors open, to talk with Diva about that, and I'll bring this one up, and then we'll have them come into committee to determine what we could do. We'll
Yeah.
try and do that as quickly as possible.
It gets into their rebate structures. I mean,
Yeah.
they're suggesting that the rebate makes it more cost effective for them to do so,
Yeah,
but they can't disclose that to you as far as I'm aware. But
yeah, no, if we want to get it right, we don't want to hold the bill up. I
Right,
mean,
correct.
what you're pointing out is an issue, and I know it's been an issue. We've heard from others about this.
Did Diva testify in the House? Did you testify in the House?
Not on H222, but the issue around the prior authorization around Suboxone was used as an example in another bill in the House where there was testimony.
I just have to say that this is incredibly frustrating that Diva is coming at the last minute when they should know that this bill has been here and that they should have been paying attention to it, because
They are.
they are holding it up right now. They are holding it up.
Well, this is a new issue. I don't think they're even.
It's been in the bill since the beginning.
David Inkleberg has a comment behind this.
Good morning, David Ingram, the Department of Health. I just want to say that David did testify.
Yes.
They did?
Yeah.
Did they bring this issue?
Mr. Lockwood was just speaking for himself.
Okay, did they bring it up, this issue up in the House?
I don't remember.
You
what
don't
he
know,
said,
okay.
but There's something right here.
So this is a new issue that we're hearing about. No one else has brought this to our attention. So if we can resolve it, we'll try to do that.
Yeah, the issue around brands as a preferred agent over the generics is brought up in House Healthcare in relating to another bill.
But it does get into the whole preferred drug list and what we get lower rates for, so we don't know. Yeah.
We don't know.
I know, we don't know what the consequences might be. Okay,
But we are largely supportive of the bill. This is, I mean, increasing access is important. You are going to see a very large boom in the dispensation of buprenorphine products because of the removal of the XDEA requirements.
Yeah.
Which does get into some other issues down the road, but we'll tackle those as they come. So we much appreciate your time. If there's no other questions.
I have a unrelated question.
okay.
When's the next COVID vaccine update?
Oh. They're talking about having it made available for people who are vulnerable, I think, soon in the fall.
Yeah, they're focusing now on the distribution
Yeah.
channels and removing that from
Health
department issues
Health,
as back into normal supply chains.
Okay.
I don't know.
Okay, all right.
Well, thank you for your time.
So Katie is here. Thank you very much, Jeff. We appreciate your identification of those two things for our edification. One, it doesn't look like changes the bill. The other one is something if we can do quickly, we'll try to do something. At least we know about it as something to solve. So Katie is here, and why don't you come up? You have an amendment that has come partially from judiciary. others.
Good morning.
Good morning.
Katie McGlynn, Office of Legislative Counsel. Sorry I'm late. Another committee tried to shoehorn me in for 15 minutes this
Oh.
morning, so here I am.
Oh, okay.
Better
Are
late
you-
than never.
We're good.
I think I'm gonna have to bop back and forth all
Okay,
morning, but
well,
that's
let's see
okay.
what we can do here.
Alex, will you let me in?
Oh, yes.
We're probably gonna have to put this bill up tomorrow morning,
Okay.
and then try to figure out how we can move it forward.
You should be all set.
Thank you.
Oh, I had the wrong bill up there.
There we go. Okay. So this is draft 3.3. You have already looked at an amendment of H222. So what this is it continues to be instances of amendment versus a strike through, but the new language was highlighted in yellow. So the first change was language we already looked at to make language about the regional stakeholder meetings be about blueprint for health and striking out language about accountable communities for health. The second instance of amendment, I need the underlying bill, is adding the department's pharmacy benefits manager. Yeah, just need one file, that's okay. Thank you. After the Department of Vermont Health Access, and that section, let's see, section 6B. Okay, so 6B was a section on opioid use disorder treatment systems. This was the section, the whole of subsection E currently reads that the DIVA shall not have, let me start over. DIVA shall not require a healthcare provider to document a patient's adverse reaction to a medication prior to prescribing an alternative medication for opioid use disorder to the patient. So this proposed change is adding the Department of Vermont Health Access or the department's pharmacy benefits manager shall not require a healthcare provider to document. Next is a change to section 8B. So this is striking out the whole section of 8B and putting in a new section 8B. It's similar to the existing language that came over from the House with some changes. So the new language would read that DIVA shall amend its rules pursuant to 3 VSA chapter 25 to enable healthcare providers and office-based opioid treatment programs to prescribe 24 milligrams or less of the preferred medications for buprenorphine without prior authorization in accordance with 33 VSA 1901L, which is amended in this bill.
And so did we run this one by, this is what, did we? run
I sent
by
this to DIVA yesterday and they
Yeah.
have not responded.
So, Madam Chair, this is the thing, the preferred medication for, doesn't that mean this is the problem that they're creating with this language, because preferred medication for would mean the Suboxone instead of
Could be
generic.
based- But it could be based on the insurance.
But if we just got rid of the preferred medication for, then it would just be or less of buprenorphine.
This is the question we have to have DIVA comment on. You're right.
I'm just wondering if this
Yeah.
is what's causing the problem,
We
and if we
don't-
take
yeah,
out that
could be.
phrase, then
Very
that would
much could
fix
be.
the problem.
But what?
No, I wasn't
Okay.
gonna say anything. I haven't heard back
Yeah,
from them. I
okay.
don't know.
Yeah, so we'll need to hear back from DIVA, but we're not gonna be waiting a whole long time for this.
Okay.
We're looking at this today. My goal is for us to come to some consensus around what we're proposing and then put it up for vote tomorrow. that's our goal. That's our.
And 33 VSA 191 L
Yep,
is what?
that is medication for opioid use disorder. It's a section added in this bill. It's in section 7 of the bill, if that helps you.
Okay.
It requires that AHS provides coverage to Medicaid beneficiaries for medically necessary medication for opioid use disorder prescribed by a healthcare professional practicing within the scope of the person's license and participating in Medicaid. And then pending DERB review, AHS will cover at least one medication in each therapeutic class for methadone, buprenorphine, and naltrexone as listed on Medicaid's preferred drug list without requiring prior authorization.
So it is related to the preferred drug list. Yeah.
Yeah, it cross-references reference to the preferred drug list.
For the record, no language on fiscal office. I caught a little bit online, and the issue in this section was brought up in the House. It's in my fiscal note. This isn't new information.
Okay.
And the estimate in my fiscal note, according to DEVA, was that it would have, based on the House language, I'm not sure if this changes it, the impact would be 1 to 2 million, but they weren't sure. And so the House took the position of, well, great, well, we're gonna let it go as it is.
Mhm.
And if it is 1 to 2 million, you come back and budget adjustment. That was the sort of stance.
That would make sense.
Because it said it could be 1 to 2 million. So they didn't book anything because it was more of a could. They
Okay.
didn't have a good number. So that was the House stance, just to clarify the record. They were aware of it and sort of said, well, come back and BAA if it's an issue.
And it is covered in our bill through the manufacturer's fee program. I'm looking at your fiscal note. You have it under that. But I think it is it in the?
No, this is different. This is section 8B.
8B, I know.
This right here.
But is it covered? That 1.8 expenditure is under Medicaid, but is there any,
Oh, it's just not a relationship.
okay, no.
With Nate.
That's all we're.
Did they talk about the generic, and if the generic is cheaper, then?
Again, I would defer to DEVA, and again, I don't know how any change in this language could change it,
Okay,
but oftentimes with DEVA, sometimes the name brands, they get a better, I'm sure. Jeff
They get a better
They get a better reboot with the name brand, and so
got
they
it.
don't always go with the generic because it's cheaper to go with name brand in some cases. So anyway, I just want to clarify the record on this.
Thank you.
I was just wondering if Jeff could chime in, if he has anything to add at this point. Could we ask him?
Sure. Jeff Hockford, Vermont Retail Drugs. This section, centers are not necessarily the place where you could do it. That other section I quoted, the 33, VSA 1901L, I think, where it's requiring you to cover a generic or a product within each therapeutic class, maybe in there tweaking something to allow, must include coverage for applicants in the non-covered period.
Well, I mean, first we have to understand what it does to the purchase of drugs through Medicaid, and if it increases costs significantly, that might not be the solution. The solution might be asking Medicaid to make a determination when people are being released, or 30 days before release, or 15 days before release, so that then they're entered into Medicaid when they walk out the door. That's a, so that's a possibility. We don't know the implications of what you're, but.
Yeah, I ran the numbers, so manager, I ran the numbers in my one store in Rutland with the Suboxone films we do dispense through Vermont Medicaid, and the delta between the gross revenue for the brands versus if it were the generic and the same fee schedule was over $800,000.
Okay, we'll have to deal with that. Thank you. Okay, Katie, and so this one has a lot of questions associated with it, and we will communicate directly with DEVA and see what we can come up with before tomorrow.
Okay. The fourth instance of amendment adds a new reader assistance heading and some new sections. So this is the language on the drug checking for contamination detection. So first we have a definition. Drug checking means the testing of a substance to determine its chemical composition or assist in determining whether the substance contains contaminants, toxic substances, or hazardous compounds. And then we have the language itself in section 12, overdose prevention, drug checking for contaminant detection. Notwithstanding any other provision of law, it shall not be a violation of this chapter to receive samples, possess, transport, or store samples of a substance that may contain a regulated drug solely for the purpose of analyzing such substance to determine its chemical composition and disseminate information regarding such analysis to the provider of such substance. On-site community drug checking service providers authorized by the health department shall be permitted to collect voluntarily provided residual samples of substances potentially containing regulated drugs, possess samples, transport, or store samples of regulated drug. I think I should say a regulated drug, solely for the purpose of analyzing such substances to determine its chemical composition as a life-saving intervention. Use any available technologies to analyze the contents of samples to obtain timely, highly accurate information regarding the composition of drugs to prevent overdose and mitigate health risks. Provide results of analysis obtained from drug checking technology to the person requesting drug services. Disseminate data containing only the results of analysis and containing no personally identifiable information to community members at risk of overdose. And if necessary, arrange for a sample of a drug or substance to be tested by an approved laboratory. And operating any drug checking service, no personally identifiable information shall be collected from a person providing a controlled substance to a service provider. In subsection D, an employee, contractor, volunteer, or other person acting in the good faith provision of drug checking services authorized by the department, acting in accordance with established protocols, shall not be subject to arrest, charge, or prosecution for violation pursuant to this chapter, including for attempting to, aiding and abetting in, or conspiracy to commit a violation of this chapter. At the top of page 4, have their property subject to forfeiture, any civil or administrative penalty or liability, or any kind, including disciplinary action by professional licensing board, credentialing restrictions, contractual or civil liability, or medical staff or other employment action, or be denied any right or privilege for actions, conduct, or omissions relating to the operation of a drug checking service in compliance with this chapter and any rules adopted pursuant to the chapter. In subsection E, an individual possessing a regulated substance and who provides any portion of such substance to a program authorized by the department pursuant to this section for purposes of obtaining drug checking services shall not be subject to arrest, charge, or prosecution for possession of a regulated substance pursuant to this chapter, or civil or administrative penalty or disciplinary action by a professional licensing board for a violation of this chapter. There should be a period at the end of that sentence. The department and local governments authorized by the department shall not collect, maintain, use, or disclose any personal information relating to an individual from the department or local government receives any drug or substance for checking or disposal from whom. Subsection G, the results of a test carried out by an authorized drug checking service provider shall not be admissible as evidence in a criminal or civil proceeding. And then in page 5, the department shall initiate rulemaking no later than September 1st of this year. And we're renumbering the one remaining section to be numerically correct. And then in the 5th instance of amendment, we're adding 2 new sections. You've already seen this language. This is related to the opioid abatement settlement fund. So first in section 13, we have language that provides more flexibility in how the recommendations from the opioid settlement committee moves through the General Assembly. And then in section 14, we have each of the appropriations themselves coming out of this special fund. And there's a new, there's a change on page 7. So page 7, subdivision 3, 1.97 million to 26 outreach or case management staff positions. And then there's a new subdivision 8 on page 8. This is 700,000 to the Department of Health's Division of Substance Use Programs to award one or more grants to an organization or organizations providing or preparing to implement drug checking services with a spectroscopy scope.
Good, spectroscopy, great.
Okay, devices, including high pressure mass spectrometer or a Fourier transform infrared spectroscopy device.
Good
job. Thank you. In a harm reduction setting. The grants awarded pursuant to the subdivision 8 shall be based on the applicant's ability to provide publicly available drug checking services. And then we're renumbering the last effective date section.
Okay, so the immunity section is the section that was worked on and requested from Sherry. And Dick Sears has looked at it, Senator Sears has looked at it, and Tanya Byhowski was the one who sort of shepherded it through. Also to indicate that I had a request from Representative Lalonde to do similarly. So that part, I think, unless we'll go through it, but then I know Department of Health wants to comment on this as well, but
Can we unpack
questions?
it a little bit? I'm concerned about who determines what's good faith.
This is
This is Michelle. This is her.
Michelle, oh
this
yes.
is her
Michelle
language.
Childs did the-
Yeah.
Yeah.
And I don't know her flexibility, but the language is language she gave me from a bill she drafted, so I'm not the expert on this.
Then what could go wrong?
Can you
Why
write
would
with
people-
the section that he's.
Let's look at it together, and then Katie, maybe you can offer some
Okay.
preliminary comments, which we probably should. But we should have you connect with Michelle Childs on this. Some of us have been through some of this previously, but we're not lawyers. I wouldn't want to give my legal opinion on it. Okay.
Okay, you want to walk through it again?
Yeah, just looking at this section, where Senator Williams, you had a question on good faith, so where is that in the proposal? I suspect, thank you, Jeff, very much. I suspect it might be something that those in the legal world use on a regular basis.
It is.
Yeah.
So again, this is Michelle's bill and she'll have more context than I can provide. But good faith is a term that's used frequently in the legal community. It's based on what a reasonable person would think an act done with good intentions, with the intention of conforming with this law would be. To give you much beyond that, I think I'd be overstepping.
I understand what it means. I'm just wondering who's going to determine if it's good faith. The courts? mean, And why would anybody have to be exempted from any of this? I mean, if they're doing what they're directed to do.
Well, they're carrying drugs that are not prescription drugs and that are being tested. And so it could be someone leaving from, let's take they're leaving a designated agency and going to the Department of Health and carrying these drugs to be tested because they're concerned about people who are using the drugs might be exposed to fentanyl or xylazine or something, some of these other awful things. And so they might be stopped. They could be stopped by a police officer. And so then the person going from the Howard Center would say, I have authorization here and the Department of Health is authorized to do this. And the police officers say, all right, I'll accompany you to the Department of Health, but I believe this is that. So I can think of a scenario.
Right.
There might be another scenario we could think of that might be the police officer say, well, I don't quite believe you. And,
So it's a lot of discretion.
it will be discretionary, yeah. Michelle could think of much better examples and give a much better explanation than I could.
Okay, okay.
Yeah, you got it.
Follow up on Senator Williams' question, is it possible that someone carrying the drug around would just simply say, hey, I'm heading to XYZ?
Yeah, they
you know,
could.
And then it becomes, the law enforcement officer has no grounds to.
Well, the law enforcement would be using his or her discretion to make that decision. So it could, I can't imagine all the conditions, but it could be someone that was not connected with any particular facility or organization.
Private individual.
It could be a private individual, and if that individual isn't authorized with the Department of Health as part of the system, then they're out of luck.
But I mean, it isn't, I'm not trying to put a damper on.
No.
But isn't it conceivable that, these testing centers are, essentially my understanding is, are relatively open, because that's the whole point, to see if there's a risk in the drugs or not, right? So anybody who's actually got possession of them would simply say, hey,
And I just tested the drug and I know it's not lethal.
no.
Yeah, but I'm saying.
I'm transporting the drug because I'm taking it to the testing center.
I've got some experience with this situation.
So I'm asking the Department of Health sitting over here, based on this language, because I know that you've reviewed it. What conditions would be in place to ensure that anybody walking along the street couldn't say, I'm carrying this to a testing center? Is there anything in here?
Madam Chair, are you asking me?
Yes, I am.
So David, in the Department of Health, I'm actually struggling, I'm gonna step back, I'm struggling to understand what the department's role is here and why we have a role, to be honest.
Yes. Okay.
So I'm happy to dig down, but I'm starting there.
Okay, well, so when we bring you up here, hopefully we'll be able to dig down a little bit. Good question, and we're gonna hold it for Michelle Childs and David Englander. Yeah. Okay. So the last section, so any questions further on that little, what we call the immunity section, the forgiveness section? Okay. I mean, this is important, and it will be important for, there's another article that I just read this morning, I forget what it was, about the contaminants that are in street drugs, but they could also flow into others, so the testing does become important.
Is David going to officially testify
yes.
in this section? So I have a question for him, but I can wait till he's in the chair and not Katie.
So any further questions for Katie at this point on that section? Well, let's look at the last part. Which is on page 8. So this came along with the immunity section, adding in, we had talked about this, but can you tell us what this is?
Yep, so this appropriates $700,000 from opioid settlement funds to the department. The department can award one grant or multiple grants to organizations that are doing this work, this drug checking work. So it would cover possibly purchasing the equipment. It would cover potentially staff time for using or training on the equipment. Yeah, and then we have language that the grants awarded have to be based on the applicant's ability to actually provide the service.
All right, so then the question for us is, this is an additional appropriation out of the prescription drug settlement that was not in the advisory committee's recommend. So, questions for Katie, comments?
Thanks.
So I want to move to David Englander. And Amy, we're gonna be late, we're late, but we'll get to it. We have time this morning, I think, to cover it.
Actually, Madam Chair,
Yeah,
just.
Oh, yes, Nolan.
Another point on, if you want me to be here for the budget conversation, I have a hard stop at 10:40, so can you,
we'll try that.
so you
We'll
know,
work as quickly as we
I
can.
know,
Yeah,
I might not be here,
okay,
you know, new versions of it, but
I got it,
I'd like to be here, but I might not be.
okay. All right, we'll get there. Thank you. Okay, David. Thank you for being here.
Oh, my pleasure.
I mean, this does involve Department of Health quite a bit in the both these two sections that we looked at, so. The immunity section, that begins on page. The drug checking on page 2, section 12. So go ahead.
So good morning. Again, my name is David Englander. I'm the Senior Policy and Legal Advisor from the Department of Health. I'm happy to be talking to you about this. So as we discussed, the Department of Health, supports the drug testing machines. It was one of the many initiatives that we proposed the opioid settlement advisory committee. Actually, all the recommendations. So what the department did, I think I mentioned this kind of very briefly, is the department made a couple dozen possible uses of the opioid settlement committee. We then forwarded that to the committee. Committee had a discussion and there were votes. That the document containing both the descriptions of those potential uses and the votes is now up on your website. Alex has kindly posted it.
Right.
So for clarity on the substance, the department supports the availability of drug testing machines for as a harm reduction measure. A few points. So one is, I'm not an expert on liability protection, so I wouldn't be opining on that. I will leave that to counsel and to Michelle Childs. As I understood it, if organizations who wanted to host a drug testing machine, they wanted liability, they would reasonably want liability protection because people are taking illegal substances or illegal possessed substances onto their site and having them tested. This imagines a program run by the Department of Health, and I'm not clear what the Department of Health's role is supposed to be here. We wouldn't want to be in a position where somebody possessed illegal substances, they said, I'm doing this pursuant to the health department, because the health department doesn't support the possession and use of drugs or illegally possessed drugs. So I'm just trying to figure out where.
I guess my question is, I see the reference to program, for example, on page 4, line 9. And my question would be, I think Department of Health could be important here, rather than saying program, is it a guidance document that might support how this happens, rather than a program? But there must be guidance documents for the organizations that would have these machines and do the testing. That's one suggestion. And then my second suggestion is, Katie, when does this section go into effect? Is it on passage?
I believe it's on passage, yeah.
Okay, so we could put it out a few months so that a guidance document could be developed. So I'm trying to think of how to have this go forward without losing Department of Health's involvement.
And I guess I'm asking, why does the Department of Health need to be involved? I'm not saying that rhetorically, I'm trying to understand.
Protect public health. Senator Hardy may have a comment.
Yeah, so David, I hear you, because I think there's a little bit of a distinction to be made between the program that might be having the drug checking machine and be doing the drug checking, and the broader program of allowing people to bring illicit substances to that. And what I think the vision, is, I think, and a lot of people worked on this, so it's no singular person's vision, but I think what the language is trying to say is that the department is involved in approving the programs that have the actual drug checking machines. I don't know what they look like, so I'm pretending.
Yeah, they look like.
Would you like me to build
Yes,
one
that's
on
it.
Play-Doh? And,
That's what that is.
yeah, anyway, so, and we want the Department of Health to approve the programs that are administering the drug checking, because there has to be some kind of oversight of the program itself. But I hear you that you being the Department of Health don't want to have responsibility for all the individuals who may be bringing the substances to that drug checking machine. And that, I think there should be a distinction made there, because you're absolutely right. We don't want people to be like, oh, the Department of Health is saying,
yes.
you know, blah, blah, blah. So I guess that's where, and maybe we probably need Michelle in the room to figure this out, but to be able to make that distinction a little bit in the language, so that you're responsible for approving the programs that do the work, but not responsible for the broader thing.
But,
Does that make sense?
But let me just interject here, because this is exactly why I suggested guidance. If the Department of Health provides a guidance document about how any program is set up for this, that's different from saying each program will be evaluated. So I'm thinking if to put this out, it will maybe resolve the problem that you're seeing. If there's some kind of guidance documents for the situation of these machines and how the testing. That's a question.
Yeah, I'm happy to look at that. I don't know what authorization looks like. That we're authorizing.
If you have a guidance document, then any program that adheres to the guidance document would be authorized, and there's no inspection system for this. So it's obviously a work in progress. I'm not thinking that there are going to be which places are going to apply for and receive funds, or which places will use their own funds to purchase these spectroscopy machines. So they're not going to be everybody going down doing that. And
right.
That's all.
So why not, if this is a grant program, and we'll get to a concern I have about that, but if it were to be a grant program, why not just have that be in the grant?
Mm-hmm.
Okay.
Right, that would be a more direct way.
Sounds good to me.
Okay.
Well, and I mean, just looking at the language, if you are on page 4 of the amendment, which is obviously where the language is, paragraph F says the department and local governments authorized by the department. I'm assuming you don't want to be authorizing local governments.
We do not.
Yeah, I hear you on this. I do think we need to make a distinction between what you're responsible for, and so you don't get drawn into
disputes between local governments and.
Exactly. I totally hear you. And I hadn't, when I looked at the language, hadn't made that distinction. So, but I also would love your suggestions as soon as possible, because you know how much I want this bill out fast.
Here's what I suggest. I think Senator my points are both well taken, and your point is well taken. I think what I'd like for you to do is to connect with Michelle Childs and Katie.
Sure.
So we can get something in here that doesn't upset the apple cart, but at the same time does provide for some reassurance.
Yeah.
On that. So can we do that?
Yes.
Because we're not going to solve it. We're not going to solve it.
Yes.
So we see the problem.
Right.
Yeah. Okay.
Can I talk about another problem?
Yeah.
Okay.
Uh-huh.
I said this, I've said this before. I think I said it again. I'm saying it for at least a third time. The department supports the availability of these machines. My concern on page 888, the $700,000, is that it seems to me that appropriation from the settlement fund violates 4774, which I think is it in here. I believe it is in this.
Violates what?
What did it violate?
Sorry, I apologize. 18 VSA 4774, which sets forth the statutory scheme of how funds are appropriated from the fund, which is the Department of Health makes a recommendation following the advisory committee.
It does. It does.
And the whole point of that legislation is so that legislators, all legislatures, not this legislature, don't substitute their judgment and their budget intentions from the purpose of the fund. So I'm just saying as a lawyer, I'm concerned that this immediately violates 4774 because it is skipping over that step. It's not a recommendation from the department that comes to the General Assembly. The Department of Health has provided a recommendations for appropriations. Alex again has posted that the memorandum that went from the Commissioner of Health to House Appropriations and Senate Appropriations. So just I can't not say that I think this does violate the law. You can certainly argue that it comes later in time and therefore you can make when Judith would say a Mishnah, we would create a rationale for it, but I think it does, it is consistent with 4774.
I don't think it is.
Katie
I
and
think it is.
no, you both have your hands up.
Well, so I take David's point and I understand why he's raising the concern. I'm thinking back to the conversation last year as the bill was moving through, there was recognition that as it went through the budget process, that like all proposals made that go through the budget process, the General Assembly would look at this and put its own fingerprints on it. With that said, if there's a concern, you're already amending that section of law. You could go in and add a sentence recognizing that the General Assembly may modify or whatever the recommendations coming through the advisory committee if you want to give yourself that authority.
Yes, except I would want to run that by the fund administrator. That was lawful. We got permission from the fund administrator. Working with the Attorney General's office, we got permission to have the language that was proposed. So there's somebody still could do that. I'm not sure that the fund administrator would agree that's consistent with the settlement with the settlements that are currently in place.
So
Go ahead.
if I can pipe in, one workaround might be just fund it out of the manufacturer fee fund and make sure that it's allowable use. The money's there.
Yes, it is.
So make sure it's allowable use, it is,
Yeah.
and make it allowable use.
Yes.
So that's a backdoor way to kind of avoid
Yes.
all of that.
I like that better than,
And the money's there.
this is the first time we've used this advisory committee.
Yeah.
We've identified a little hitch in it, but I don't like putting the money in from it automatically the first time. So the manufacturer's fee fund, if we could modify that language and use the manufacturer's fee fund, this is
Yeah,
vision
that's
for
a,
the
I mean,
community.
that's a question for Jen. That's her
Yeah.
subject area, but
So
we
it's
can,
either,
we can run
I love
by her.
having lawyers.
I know.
Let's do that because I think we can, let's do that and you can connect up with Jen. Yeah, just for efficiency's sake, I think we should do that.
I need to do that.
And not, I don't wanna bypass the process that's currently in place. I do think that's important. At least, this is the first time we've gone through this process. So why are we don't wanna violate, but we also see this is a recommendation from the Department of Health and we all seem to be on board with it. Go ahead.
I mean, just looking at the statute as amended in the amendment, sorry, I don't think it violates it at all, because it just says that the department shall submit a spending plan informed by the recommendations.
Yeah.
And then the General Assembly,
Except the department hasn't submitted that as a plan to the General Assembly, and the opioid advisory committee hasn't voted it as one of its priorities.
but this doesn't supersede the statutory and constitutional powers of the General Assembly. The General Assembly by constitution has the power to appropriate funds.
It sure does, which is why I was saying that it is certainly it's certainly within the power of the General Assembly. And why it comes later, because it comes later in time, you could say it supersedes this.
Yeah.
I think it violates the terms of this paragraph and its intention. I'm not saying General Assembly couldn't do it.
Right, I disagree. I'm not a lawyer, but I love to play one on TV. But what I'm more concerned about is does it
Yes.
violate the agreement of the fund, like, but I can't imagine how it would. But I think we have one of the more stricter statutory constructs for that fund than other states do.
Theoretically, they all had the same construct, but as you know, we've talked about there being more flexibility.
So,
Exactly.
yeah, okay. So let's see how we can do with the manufacturer's fee fund. Katie will connect
Yeah,
with
I will.
Jen, and then so that we don't get into this is the first time we've used the advisory committee process, and I'm really not interested in upsetting that apple cart.
I do feel the need to note that because it's not in the governor's FY 24 recommend.
Hold on a second. No, wait for that. Okay.
The department
Yeah.
wouldn't be in a position to support the 700,000 on the manufacturer's fee fund. It isn't an allowable mechanism as no one.
Who?
No, I mean, what you described is legally is exactly right. That
Right.
they could be appropriated so long as you made it available.
We can
Appropriations.
we can add it to the list.
I'm just saying that, but the department couldn't support that because it's not in the proposed budget.
Oh,
On the round.
I got you. I got it. Okay, well, that's a different
That's a
discussion.
different, that's a
Totally
chemical
different
fish that we
discussion.
put aside. I just wanted to say that for clarity's sake, so you're not
But,
surprised.
well, so
But we can do that.
He should stay on the record.
I know, but I just don't want any hiccups when the bill gets out of the general assembly.
It won't. So I want to move, so I think we've gotten to the middle of where we are. So we'll connect back with Katie and Jen. We'll figure out that whether or not we're going to do that language. The question is whether or not we include the $700,000 from the opioid settlement funds. That's a big decision. There is some validity to not wanting to step over the lines the first time we go through this. On the other hand, the $700,000 could go a long way for the testing and establishing these sort of programs. So hold it right there. I do think that when we come back tomorrow, we can make these decisions based on what we hear from DEVA, what we hear from our ledge council, and we can move forward on this bill. I'm not thinking we're gonna have to hold up. We can make decisions to go. Don't want to go. But Michelle is here. Hi. Thank you for putting this language together.
Sure.
So we've been looking at the sort of what we call the immunity section. And Senator Williams brought up a question regarding on which line was it? Senator Williams, you had it.
It was good faith.
Which one is it?
It was good faith, the use of good faith.
Right.
What is good faith?
The good faith
Who
language.
determines what's good faith and what is it?
Well, I think that there was an issue and that involved the court, and good faith is a term that's frequently used. And it means just kind of plain language. What it means is that you don't have a fraudulent intent. So in this context, it's that an employee, so if you're looking at, I think on page 3, subsection D of the amendment, I don't know if y'all have the same
Yeah, we
version,
do.
but probably. So volunteer or employee acting in good faith provision of drug checking services, that's, just as long as that it's they're, trying to comply with the intent here and following the rules, that would be considered a good faith provision of services.
What about good faith on the part of the individual who's,
Stop.
he's got possession of illegal drugs, but he uses the excuse that he's heading to a drug testing facility to determine the quality or contaminants in his stash.
Right.
Good faith, to the state trooper that's pulled him over, hey,
I don't know, maybe that trooper wants to fall into the drug checking center if there's a concern.
Right. And so there will be some education around this.
I'm sure.
Yeah, so, I mean, it doesn't just happen automatically. Which is another reason for my suggesting putting the date out for the effective date for this section just out a couple of months. And I'm thinking that if there were guidance from Department of Health and programs have to get set up, they have to buy all the equipment, they have to do all this other stuff. But having some time for implementation, transition, something to think about. Michelle, you want to say?
So is there any system of tracking this substances that are going from one of the clinics to a testing site? I mean, there's some opportunity for some black market opportunities here, I think. Somebody's going, they say, well, I've already tested this substance, got a little fentanyl in it, but not enough to kill anybody. And if you're not tracking it, somebody didn't, like a chain of evidence that nobody's tracked it, they left the clinic. I just think there's opportunity for misuse here. We don't specify it.
Two things. I think if it's somebody who's a dealer or who's trying to sell large amounts of opioids or other substances, that wouldn't be good faith. And it would be pretty clear that that person is doing it for illegal profit, not because they have opioid use disorder and are trying to make sure that their own personal supply is safe. And that's the purpose of the program. It's not to make it easier for people who are selling these substances in quantity to, purify their substance. And we also did get testimony from people who work on the front lines. And I think if I've heard so much testimony on this issue. And from law enforcement that, the information about the supply is actually shared more broadly to say, like in Brattleboro, we found xylazine in this when we were testing it and putting out alerts to let people know there's xylazine in these compounds in Vermont as a public health provision, that this is actually a really important public health tool for people to understand what's out on the streets in Vermont. Does that make sense?
Yeah, and I get it.
So
it'll take.
Could have rat poison, or.
Yeah.
Right.
So I'm just saying that I almost think there needs to be some kind of a tracking system so that.
That would be the next step to consider, but.
Well,
right
I think
now,
there's a fine line between what you track and because this is not supposed to be to quote unquote catch people. This is supposed to be to protect people. And again, it's not for the dealers, it's for the people who are sick and using, and we want to make sure they're protected. So I think we have to be careful with threading the needle. And the good faith language is absolutely, I think Michelle's point is like, if you don't feel like somebody's working in good faith, you watch them and see if they are. And, I think most people who are going to be doing this are doing it because they want to protect themselves or protect people they know or love who have opioid use disorder.
And I'll just say one more thing if I might, and I'll end it. But, we keep treating the symptom and we don't even acknowledge the problem. The problem is that if that stuff wasn't coming in, these people wouldn't have access to it. And we wouldn't have to be doing what we're doing with this bill. So.
Yeah.
And I'd like to see some action taken at the other end of it.
We'll have to have a chat with our friends next door in judiciary because they have been working on that.
So I feel better.
Yeah.
I reminded my colleague the other day, though, that a lot of folks are addicted because they were prescribed by their medical professional and large pharmaceutical companies.
And everybody's different.
Right.
It takes a different dose to affect some people. So, and I get that. I've lived through it. I know. So.
I know you know.
Right. And the Vermont prescription drug monitoring system in this state is seen as one of the best in the country. We still have the problem. Any other questions?
I was just gonna mention, and you may have heard, I haven't had and been around any of the testimony or anything of this, but so maybe the witness had mentioned is you do have precedent already on the books kind of in with this kind of approach with your immunity for
Yes.
reporting an overdose in terms of saying, you know, someone is in possession of something illegal, but we're gonna prioritize public safety and getting help for that person.
That's
And so,
important.
you know, put that aside. So it does build on something you passed, gosh, it's been several years now, it's been a while.
Work. Okay, what, Senator?
Just a comment. So overall, I support the bill. I just do see an unintended second order consequence here that this testing can be used as essentially a black market marketing tool. You know, I've tested my stash and it's,
Well, there, well, but
that's,
there will be.
That's
guidance.
not good faith.
That's not.
I know it's
faith.
not, but it's an unintended consequence of good faith, of our good faith.
Well, it
We're all
will,
good people. No, I'm telling you, it's gonna. Mark my word.
okay, we'll sort that one out as we get there. We'll have we can have a further conversation on that. I'm not sure that that's gonna play out either in the same instance that Michelle was talking about. It hasn't played out either.
Maybe we should
Yeah.
work on a decrim though.
So, I'm gonna quickly turn to Nolan, and just tell us what we have here, Nolan. I'm gonna hand it out to folks, and then we're gonna move right to 94. We're coming back to 222 tomorrow morning with the intent of moving it. With all the little changes, the big decisions and the little changes. And so I'll just hand this out. You gave me the whole stack.
I gave you the whole stack,
Yeah.
and Alex has posted it. For the record, Noel Langwell, Joint Fiscal Office. My apologies in advance. I CC'd everybody, and I kept sending out new versions, and I would get emails from people saying, that's not what we said,
More
or
in
you
it.
did this, or you forgot to include that. And I want to make sure that I'm capturing people's messages correctly.
Has this been updated from the last one?
Yes.
This is totally.
You
This
have
is the latest.
Thankless job.
Thank you. I tried to put the dates on them. And so what I've tried to do is capture what the different pieces that people who came in and asked for. Obviously, there's other things that people want who didn't come and ask for it. But this captures the conversation. Tried to capture who asked for it, what the request was, what the request amount was, what the House did or did not do. Then try to have some notes to try to explain it. And then I included the links with the handouts. Usually what happens is if it was already in the House, I tried to, you know, if they were just asking for the same thing that was in the House, I just tried to say support the House. That's what they were saying. If the number is different, it usually meant they were asking for more. Except now I look at the development of disabilities, and I think that's one example of where I put it in both places. So I tried to do my best to put this together as quickly as I could with all the free time that I have. And I'm hoping that this will be a useful resource to you. And when you look at it, you won't have any additional questions because it's all clearly laid out.
So, and just, I really appreciate your taking this and structuring it for us. And the good news for us is, I think the bills that we've sent out haven't had significant, except for one, the childcare bill has had.
But that's already in the budget.
funding, but that's already in the budget. So the other bills that we sent out don't have to be listed.
Getting a look from
this year.
Senator Weeks.
No, I'm
No.
just listening.
Okay.
So these
You
are,
got that.
this is all the testimony that we've taken and people who have talked with us about needs that were not included in the budget. I'm not certain that there's a way that we can prioritize one or over the other. I think we have talked a little bit about if you're gonna fund a pilot, you may as well should fund the whole thing. Put it in place, and I think appropriations will be looking at that. Appropriations will find this useful in decision-making. So, and since we have this first in our hands for the first time, I'm gonna say, let's hold this. We're gonna try and come back to it as close, for some time at the end of the meeting and look at it. And I will there's no way that we are going to be able to go through as a committee and make concrete decisions, although I know that you have your own individual priorities, and I think those are the things I'd like to hear about.
We may not be able to come to a consensus, but I get the sense that we've all been hearing from constituents over the last, whatever, 7, 8 months. And I mean, for me anyway, there've been a couple of themes that just keep coming back. And that when we have this conversation, I will bring those up, but yeah. Right now?
Yeah.
Oh, the need for more beds for
Yeah.
psychiatric care and mental health. I mean, that is one that just over and over and over again. And home health care and home care services.
And those have been significant, yeah. And so the need for beds, which is exactly why we worked with economic development yesterday and took that testimony, and that I've been talking with the HCB regarding that, and then trying to leverage some of the money that's in the S100 for housing, and we're also having that conversation of appropriation. So I think there's a lot of interest in trying to build that capacity, but it isn't easy for 2 reasons. One, takes time, but 2, workforce is a big issue, but certainly, and both of the concerns that you've raised. All right. Anyway, so we will come back to this. But those 2 are important. If others agree with you, we can highlight those. Okay. Thank you.
A pleasure.
Good work as usual, and we appreciate it.
I will not be here for the rest of the morning. My apologies.
And we have the fiscal note for the opioid bill as well.
Well, not the latest.
Not the latest, if we change it.
If you change it,
Yeah. Okay.
You've got $8 million and it adds $8 million to the amendment. But, you're covering 7.3 out of the
Right,
fund, and then the other 7 may or may not come out of the,
right.
so you're covering your costs.
So the 700,000 is either from the opioid or the manufacturer. Okay. All right,
And I will have a fiscal note for you when you pass it.
thank you very much. And we fit your schedule. So let's move on to H94. I'm hoping that we can go through H94, hear testimony on it, and then we'll take a break and go to H171. So is Miranda outside? And so just as a reminder, H94 is the rateable reduction. So remember, determination is made for what are the basic needs for a family in reach up, and then it is cut essentially by 49.6%. And so this is looking at removing or lowering that rateable reduction, the 49.6. That's what's in the bill. Good morning.
Good morning.
But you are not Miranda Gray.
Good morning.
Wow, did you guys coordinate or?
Two of you.
Yeah.
And so you're going to be testifying together.
Yes.
Okay, and Katarina's in the corner, so we have all
Yeah.
3 of you. That's great, thanks. We don't like, not that you're in the corner, but that you're here.
Oh.
Yeah.
I won't read it.
And do we have your testimony? Yes, we have Aaron's testimony. And that speaks for all 3 of you.
Yes. it
Okay,
does.
good.
Would
Thank
you like me to share that? once I
Sure.
get that to you? Just looking for the Zoom link that Alex had sent me.
Oh, I can send it for you again.
Sorry, I think I have it right here.
Amy, that's not a rose, is it?
It is not.
It's not a rose.
It's nice and full image.
Just while we're sitting here, I had a conversation with Calvin Cutler of Channel 3, and he, after we went up to Jenna's Promise, and he got very interested, and he's going up there this weekend to take a tour, and he's working on a broader report on all of this. So it's really terrific, because I think it's one of those things that's hidden.
Yeah,
People don't know about.
yeah. Awesome.
Awesome.
Yeah. The more people know, then the more they'll understand the need and the community support that's necessary to make something like that happen.
Yeah, I heard support from every state level campaign
Yeah,
effort.
Yeah.
Was really curious.
yeah.
That's
Great.
Thank you for the opportunity.
No, it was a great day.
Okay, here we are. So why don't you introduce yourselves for the record, and we're listening.
Thank you so much. Miranda Gray, I'm the Deputy Commissioner for the Economic Services Division. Good morning, I'm Erin Olikin, excuse me, Director of the Reach Up Program.
Have you been in here physically? Yeah.
I think I have, yes.
Well, you know.
Not for a while, but.
I know, that's what I was thinking. Okay.
We're gonna jump right in. Erin's
Please.
gonna give just a high-level summary of what Reach Up is, and then we'll get more into the rateable reduction, that is all. So just a brief kind of summary of the Reach Up program is that the Reach Up program provides financial assistance to families with minor children. And adults who are participating in the program are provided with coaching services. And that coaching is designed to help them develop goals and improve their financial situation through increasing their income. So that could be through training, through education, employment, and in some cases pursuing SSI. And part of that coaching also addresses any obstacles or barriers to those things. And so we recognize that it's really important to meet people where they are, and that could be anywhere along that journey or spectrum to employment and education. And so each of those goals are important in that process to getting to improving the family's income. Case managers, also some of the other things that case managers often work with families on are things such as mental health for both the adults and the children, children's health and school needs, domestic violence, transportation, housing, finding quality child care. So it's really a very holistic approach to providing case management and a whole family approach. So our mission, which we developed about, I think 6 or 7 years ago, is that we join families on their journey to overcome obstacles, explore opportunities, improve their finances, and reach their goals. And our vision is that families will be empowered, connected, and thriving. So a few kind of numbers and demographics around the program that might kind of help with the context. We have about 3,400 households participating at any given time on average. That number is slightly increasing, but it's been fairly level. Of those 3,400, approximately 1,100 are called child-only grants. And that means that only the children are receiving the financial assistance and the adults are not required to participate or engage in the coaching case management piece of the Reach Up program. So we have about 2,700 adults participating in coaching services. And the reason that 2,700 plus 1,100 do not add up to 3,400 is because we have some families that have more than one adult participating. So it could be 2 parent families. The maximum monthly grant for a family of 3 outside Chittenden County, just to kind of get some perspective on the numbers that we're looking at, is $856. Any countable income that that family may have, such as from employment, from unemployment insurance, child support, is deducted from that maximum grant after any applicable deductions. So there are, for example, for employment, there is an earned income deduction, and that's a certain amount of money that is deducted from the income before that income is counted to offset the grant amount. Reach Up is funded through the federal TANF block grant and general fund. The block grant has been level funded for over 25 years. So that means that the same $47 million that we got more than 25 years ago is the same amount that we are getting today per year. That it does not increase. It is not a federal entitlement program like SNAP is. So for comparison, SNAP will draw down more federal dollars the more people are participating in the program. That is not the case for Reach Up. We will get the same amount of money no matter who or how many people participate. So DCF also leverages the TANF funding to serve families, Vermont families that meet certain eligibility criteria throughout the department. So approximately $4 million goes directly to family services. Approximately $9 million goes to CDD, Child Development Division, to pay for childcare for these families. 19 million approximately, it's always a little bit different on any given year, goes to the earned income tax credit to the tax department. And what happens with that money is then we get a match that comes back to us in the same amount as a special fund. And so it turns into maintenance of effort funds essentially. So it becomes part of our matching funds that we can then spend within the Reach Up program. The Reach Up budget is actually made up of approximately 2/3 general fund. So although we do get the amount in TANF, that TANF funding goes throughout DCF to support families in different ways. And so the actual Reach Up budget is about 2/3 general fund. So the next screenshot I'm going to show you is from our legacy access system. And just as kind of an overview, what this shows is an eligibility computation. And in Reach Up, the eligibility computation serves as both the eligibility income limits and the maximum grant amount for the family. So it's a little tricky to explain, but I'm going to do my best, and you feel free to ask questions.
I'm just gonna pause for a second because it looks like not all of our pages came over.
We got it up.
Oh, you are changing?
But they're not up there.
Okay, yeah,
We don't have that page.
yes, sorry.
Okay.
I'm gonna work on that.
Okay, all right.
I'll talk in the meantime.
All right.
I can always
I have a
talk it
question
out.
in the meantime.
Of course.
So we get $47 million from the federal government. That's the block grant. That's distributed as you have there. Now, then the total budget includes general fund. So the total budget, which is then 2/3 general fund, is how much?
The total Reach Up budget.
The total that we're talking about here, where you say Reach Up budget, yeah, is 2/3 general fund. So what's the total?
Oh, right. So
That's the 23 million down below. Is that added into the block grant then, the 23? What are we, I'm not.
no,
clear.
so the total Reach Up budget is all the pieces of this pie added together. So it's usually around 34 million.
Okay.
The total TANF block grant is 47 million. But a big chunk of that goes to family services and childcare right off the top.
Ah, that's right. Okay, so the block grant is not designated only to Reach Up. And so we need to be clear on that. So that includes the EITC link. Yeah, okay, the tax credit.
Are these per year numbers?
Yes.
Yes. Yes. And when you talk about SSI people, while we're just holding there, can you explain what SSI means?
Sure. SSI is supplemental security income, and that is the portion of social security income that is for folks with disabilities and over a certain age when they do not qualify for SSDI, which is income that, you know, that we have paid into through working. And so sometimes children will qualify for SSI, and sometimes adults who do not have a work history or don't have much of a work history. So a family who is applying for Reach Up, if they have SSI income in the household, that income is not counted against their grant. And that person with the SSI income is not included in the eligibility computation in terms of the household size, because they have their own income source through SSI.
You're talking the tax, for tax purposes?
For the computation of the grant.
Okay, so why don't we go to, we don't yet have that. I just tried to refresh and get it.
Yeah, no, you will have it. Hopefully soon.
Cool.
So in the meantime, I can explain how the grant is determined.
Please.
Okay. So the way that the Reach Up grant is determined is by taking a basic needs standard, adding a shelter expense, which is a specific housing allowance. And then once those two numbers are added together, it is ratably reduced. And the ratable reduction percentage that we use right now is 49.6%. So the basic needs standard that the department uses is from 2019. The housing allowance that the department uses is the average housing costs that were reported by families in 2001. Those two numbers are together. So that's where the number 450 for inside Chittenden County and 400 outside Chittenden County are added to the basic needs standard. That number is multiplied by 49.6%. And so the 49.6% is, if that number were increased, that would mean, like, let's just say we multiplied it by 60%, that would be 60% of the total amount is the grant that would be the maximum grant that that family could receive. So currently it is 49.6% of the total amount is what that family receives. My understanding that was put into place many, many years ago, decades ago. And my understanding is that the reason that was put into place is because the Reach Up budget had a specific allocation and are directed to give benefits that are within that allocation. Obviously, we can't overspend what allocation we have, budget allocation, and the 49.6% was the number that was come to stay within that budget allocation. And then that has stayed since then. So what happens is that maximum grant amount is used as the eligibility threshold for that family size. So unlike some other programs that may use federal poverty level, Reach Up actually uses the eligibility computation itself to compare it to then the income in the household. So if you, for example, when you are able to see the screenshot, the grant amount, the maximum grant amount for this particular family is $735. If the family has income exceeding $735 a month, then they would not be eligible for Reach Up. If they had, it would differ a little bit if it's earned income such as employment versus something like unemployment insurance. What is called unearned income is things like unemployment insurance, workers' comp, and those incomes are deducted dollar for dollar. So if this particular family where the maximum grant amount is $735 had unemployment income of $800 a month, they would not be eligible for Reach Up. If this family had unemployment income of $500 a month, they would be eligible for a $235 grant because it would be subtracted from the maximum grant amount. So in the way that the current eligibility system is, if that maximum grant amount increases, more families would be eligible, because that family who had previously made $800 a month in unemployment, if the maximum grant amount was, say, $1,000 a month, that family who previously was not eligible would now be eligible for a $200 a month grant.
Aaron, it might be also helpful to share from Act 133, the earned income disregards that will be in effect in January.
Yes, so currently the earned income disregard is, and that, what that does is it reduces the amount of countable employment income that is counted against the grant. And it's currently $250 plus 25% of the remainder. And the number that you come up with after that calculation is what is deducted from the maximum grant amount. In January of 2024, because of Act 133 that passed in the last legislative session, that number will increase to $350 and 25% of the remainder. So that's changing a little bit. And also the child support pass-through is also changing a little bit. And what that is that currently the first $50 that the family receives in child support does not count against the grant. So if they're getting $350 a month in child support, $300 would count as a deduction from the grant, maximum grant amount. In January of 2024, that number will change to $100. So it means that they get to keep a little bit more of their child support without it being offset against the grant.
So there's a lot in flux right now. That's what I'm hearing.
Yes.
Plus childcare. Okay. Go ahead.
Just a background question. Is this like a check cut, or is this services like, accumulation of services? Whether it be childcare, or is it really just a check that goes to the family and they determine its real utility?
Right, this number that I've been talking about in the eligibility computation is just a check. It's just cash. And then in addition to that, a family may be eligible, usually they are eligible for 3 squares and childcare subsidy and other things. And then if they're participating in the coaching aspect of the program, they're also eligible for some support services which help them to meet their goals. So if they need winter tires to get to a training program, things like that, then we have a special fund of money to pay for some of those things.
So that includes, because you started the presentation with, it's essentially, it sounded like a lot of coaching, a lot of, support to move them further economically than they are today,
Right,
as opposed to cutting a check.
right. It's kind of a whole package. There is the check, and then there's
Right.
everything else involved as well, including coaching,
Okay.
right?
And then to the point about childcare, I know it's in flux, but it's got a pretty positive momentum behind it. Are you willing to recognize that and reduce the impact of childcare, considering that probably everybody that's in this program is going to be covered 100% with zero copays? Is that a position you're willing to take to lower that requirement, to eliminate the childcare element of the line item here?
Oh, the money that's transferred to childcare, you mean?
Yeah.
Mhm.
Would that simply go away?
I think it would be something that we would need to look at if that need is being met in some other mechanism or not. And I'm not sure that has been contemplated if that was pulled out.
Subtraction.
Right.
Subtraction's good too. It's not always addition.
What I would just say about, and I should say this, sorry, Katarina Lesias, for the record, Senior Advisor to the Commissioner at the Department for Children and Families, is that shifting the money from division to, for the TANF block grant also meets other requirements in our Reach Up program. So simply just subtracting it from another division doesn't have, that is not the only implication on the program.
Not tracking that, but I'll keep listening.
Okay.
Thanks.
It takes time to get. Okay, Anything else? What else? Is there anything else here that we need to look at? And then the bill itself, maybe comments there.
So just I think just moving on to kind of some considerations, some things to think about. It is just important to understand the impact of how on household benefits, considering, as family's benefit is changed, it does also impact federal SNAP benefits. And so that's just something to consider. And so that means that less federal money can be drawn down in the SNAP program if families have a higher Reach Up grant, because they would be receiving a smaller 3 Squares benefit. The Economic Services Division has also run an analysis on cost increase to decrease to what it would mean, to increase the maximum grant and reduce the rateable reduction or increase that percentage. And that analysis is available. And one thing to consider, though, is that does not consider the increase in caseload that we anticipate would happen because of how the calculation is embedded with the eligibility is embedded with the actual maximum grant amount. So we do know that more families would be eligible for the program if the grant was increased. It's very difficult. It would be a lengthy analysis to determine exactly how many, because it's a bit of kind of, we don't know what we don't know, but I think it would probably include looking at census data, other programmatic data where we have income information about those families and seeing kind of like who would we be missing, who would then be included. So just something to consider in that kind of larger context of what that would mean.
Makes me that comment makes me very uncomfortable. I mean, because don't we have to have a fiscal note related to this thing that if we, no.
So maybe you could respond to that.
That's how my world works. If I'm advocating a change to a program, I come with a price. I have to. Not true here.
I believe that H94 is just asking for us to provide a report.
Yes.
And so that is why
Doing the fiscal note, getting the information.
So it's that
correct.
complicated.
Yeah.
Okay.
So then the question is, how much time will it take to accomplish that? What's needed within the department to do the work? And I mean, I don't want to compound the fracture, but I do share concerns about, I don't know I share, but I have concerns about the ability to do all of this at the same time that all the childcare work will be going on, because I know that's going to happen. Definitely gonna happen.
Well, it would,
yeah.
I think actually it would clarify for them. They would, in their financial summary.
Yeah, maybe. You'll have to ask, will it?
So I can comment on the timing of the report as currently outlined in H94. And the department definitely appreciates the opportunity to provide this information. I think there are a lot of complicated intersecting pieces that need to be considered and fully understood within an entire system, really. Childcare, all of DCF, and and how all of those things interact with each other. It's just really important to be very thoughtful about that so that we are considering it in the full context of what is happening across systems.
Could you do it at the same time that you're doing the childcare revamp? I mean, not knowing right now what that's gonna actually look like, because the House and the Senate are still working on that. The governor's budget is different, but what information would be available before, during, or after the childcare?
I can speak to that.
Okay.
I would say that from what I've heard in the House committees, is they're still talking through the timelines of the reports. And to add this additional component, we just have to think about how that's possible. And then I would just reiterate, while we're all under the DCF umbrella, ESD is separate from CBD. So we just have to be careful to think through who are on the groups for the childcare bill and who would need to participate from ESD or how would they participate. I don't think it's impossible, but I think there are considerations to
Okay.
And some other considerations for my small team who would be, I think, writing the report without additional resources to do that is that we are very busy implementing Act 133, which includes both changes in eligibility. I mentioned a few of them to reach up, and then also the coaching piece. And so we're embarking on a really big piece of that throughout the next months in working with our federal partners, and we're getting technical assistance on really implementing a very robust coaching training for our staff. So we're and it kind of requires a lot of, revamping of forms and procedures and rules. We have another round of rules that we'll need to put through the rulemaking process. We've also put together a Reach Up advisory group, which is participants to help us with this planning process. And that's really important to us, that we are engaging the people who are using the services to ensure that we are designing something that will truly work for them to help them achieve economic mobility. We're also working on the governor's fiscal year 24 budget proposal for the Reach Ahead pilot, which would support families who are transitioning off of Reach Up. And that is also a lift for the team. We also have a team member who has been pulled a part of the time to work on the integrated eligibility project. And that is really kind of moving full steam ahead right now. We also have a team member who has been pulled to backfill positions who have been pulled for the Coordinated Care Housing Resource Team. So you may have heard of it as the CCHRT. And so we have been providing staff coverage for district staff that were redeployed for this project, and they won't be returning until July of 2023. And we're also winding down the Reach Up Emergency Rental Assistance Program, which was $15 million a year program that we stood up very quickly. And our staff are working considerable amount of time on winding that down and ensuring that families have all the information they need so that they know, what to expect. And there's a lot of change going on right now. And so the timing of this report would be a bit challenging for our team to accomplish.
Okay, thank you. Thank you for the look at Reach Up as a whole and how you're making all your calculations. That's very helpful. And then this list is helpful. And I know that in appropriations, we just started looking at Reach Up yesterday and looking at the pilot program and others. So this fits in with that discussion. Quick question.
When we hear about Reach Ahead, I'm hearing all these additional things.
Reach
that we
Up,
don't
Reach
know
Ahead.
about.
Can you just talk briefly, really quick, because we want to hear from Amy Rose.
Okay.
Well, I don't need to hear it right now.
Oh, you don't want to hear it?
I'd like to hear it
Okay, that's good.
sometime,
All
yeah.
right. Well, and they're here, so
Okay.
you can
Well,
walk
okay.
out into the hall when we
You can do it,
quick
but-
break.
I can do it.
Yeah, okay.
So Reach Ahead is our transitional benefits program that supports families who are working and have left Reach Up. They tend to be fairly low income still, but we are working on improving that and helping people get into higher wage jobs. But the pilot enhances, I would say, that program and provides significant incentives at 6, 12, 18, and 24 months if families stay employed and they stay on the program. And we also provide the coaching services and kind of job retention support to help them stay employed. So that's essentially in a nutshell what that would be.
Thank you.
You're welcome.
That was good.
But I'm always happy to come back and say
That was
more
worth
about
it.
it as
That
well.
was great. All right, and thank you. Thank you all for being here, going through that with us. Because when you hear rateable reduction for the first time, whoa, what is that? Amy Rose is here. And we'll hear from her.
I also have some slides that I'm going to attempt to share.
Okay.
You should be all set on that.
Working.
I see you have information on Reach Up itself.
I do. I'll try to kind of condense and move around. Just
I
in
think,
light of
you
the
know, if
past.
we could, get your testimony, that'll be helpful,
Great. So,
because we've just been through, I think.
yeah, of course. So for the record, my name is Amy Rose. I'm a policy associate with Voices for Vermont's Children. I have prepared testimony, but just to start with a comment based on the previous testimony around the timeline of the report. So this is a topic that did come up in House Human Services when the bill was first heard. And the original date for the report was a bit earlier. It was back in November, because the hope was that this information could be used as preparing for the next session. And House Human Services did offer, did ask questions around would a consultant help with this process, or what could be done to kind of help support the report being created, and eventually moved to delaying the report to the date that you see now in H94. I think the hope is to have the report before the crossover deadline in order to, one of the key parts of this bill is to have an actionable plan. And so my suggestion would be to try to kind of keep that compromise that was made and have the report available as soon as possible. I don't think it's a very complicated report. It's not a big request. And so we've been using the Family of 4 guidelines when we come up with our sort of charts about what Reach Up and available reduction does, but using the department's own figures, they used a family of 3, right, which would have a maximum benefit, they said, of $735 per month. And so I did my quick, calculations. So that's about $8,820 a year that we're asking a family of 3 to meet all of the basic needs on. And so if we eliminated the available reduction, we know it's about half, right, at this moment in time. So we know we'd be asking for a family that's receiving $16,000, $17,000 a year to meet all the basic needs for a family of 3. And so I think if they were able to provide the numbers or a range of what that might look like, the idea for this bill is really to say, within the next 5 years, this is how we could work towards a goal of getting to that very basic needs standard. So I'm going to start with my testimony. Some of that I really appreciate, first of all, the opportunity. Thank you for inviting me in to talk today. Some of my comments do mirror sort of the budget testimony, so I'll try to skip over that a little bit, but feel free to interrupt me as I go, or guide me if you feel like some of the information is a little bit redundant. So there were 2 bills, just to kind of give a little bit of context, that were introduced in the House around to restructure Reach Up. One was H93, which did not make the crossover deadline. That bill would be looking at a new standard for determining the basic need and housing allowance. And that came from just sort of hearing the picture of how we get to those numbers and realizing it's very complex. And so it's really difficult for families to understand how their benefits calculated, which makes it really hard to sort of work through the process of just coming up with a simplified option. And as you heard in the budget testimony, Reach Up does not automatically use current year estimates to determine these stipends. Aaron already shared that information, so I'll kind of skip over the numbers. We also talked a little bit about how, there's other intersecting supports that happen for families. And so we know that with the loss of SNAP emergency benefit, families who experience Reach Up are now in April this month starting to lose about $100 of their benefit each month. And so I just highlight that to say that your timing is really great in terms of looking at this issue. What we know, and I'm just gonna go back for 1 second, is that although we don't use the federal poverty guidelines to determine the Reach Up basic needs estimate, it has kind of mirrored the amounts over the years. And so if we look at sort of the JFO basic needs estimate, we know that the Reach Up basic needs estimate is about half of that. And then when we apply the rate of reduction, we're getting to about half of that. So again, this is for a family of 4, but we're asking families to meet all the needs of their children and themselves on less than $1,000 of a basic needs stipend per month. So I just want to share a little bit, because we're Voices for Vermont's Children, of how this looks for children. So we know that our children's health and well-being are intimately tied to the health and well-being of the adults in their lives. and to the resources that they have available to them. Something that we have seen play out broadly in the context of the pandemic. When it comes to serving the needs of children, the pandemic has taught us an extraordinary amount about how and where we can do better. While Vermont has stepped up its response for children and families, the pandemic has clearly exposed the cracks in our systems and helped us to understand how deep those cracks go. We have seen that a strong social safety net protects individual people from extreme hardship. And in doing so, it strengthens communities in Vermont as a whole. Perhaps most importantly, we have come to understand that our health and well-being as a community is intimately tied to that of the individuals that compromise it. Vermont is in a position to create a structure that works for children, youth, and families. The state's budget is complex and it's sophisticated. We choose to invest many of our TANF dollars in things like childcare, EITC, and some in child welfare. This does allow us to maximize our federal dollars, but it requires us to use other funding mechanisms like our general funds to ensure that we are not asking the impossible of families in most need of cash assistance. I talked in the budget testimony about the higher need continuum of care, and I think it's really something important to consider. You know, I have spent a lot of time hearing from foster parents and guardian ad litems, from folks working within the foster care network. And what I hear is that oftentimes, you know, a family's inability to meet the basic needs creates an intervention. And oftentimes that intervention leads to foster care placements, and it kind of moves folks deeper and deeper into the system. We know that that's expensive, and we know that it's not the ideal situation for children, youth, and families. And so when we're asking families to provide all the medical care, transportation, food, and all of those pieces, and housing with less than $1,000 a month, we know that pieces of the puzzle are missed. And that often creates trauma that is exposed in classrooms and beyond. I just kind of want to share a little bit about the connection that we're hearing more and more from mothers who are in unsafe settings in their homes. Without a financial safety net, they're stuck deciding which terrible option is best for their kids. If they don't have the capacity to meet their basic needs, they fear the court will grant custody to the unsafe parent. They also worry about the unknown dangers of emergency housing options. So having a safety net gives people space to make the decisions that are in their children's best interest. If the committee is interested, maybe outside today, because I know we're tight, but I can share some stories I've heard just within the last couple of weeks and also within the last year or two about that kind of put all the details into place for that. In times of crisis, we often speak about our belief in the resilience of children, but leaning on children's ability to endure untenable situations should not be a primary strategy. Repetitive trauma is harmful. We need parents, neighbors, caregivers, and early educators who can wrap children, youth, and families in support. We need to listen to children when they are showing signs of stress and act decisively to reduce it. We need to allow them to express their full range of emotions and create an environment where healing is possible. When we assess the broader picture of our resilience as a state, we must include everyone in that picture, not just the most visible. Meeting basic needs is the very first step to addressing persistent poverty within Vermont. I'm going to skip on to the provider network piece. So you have heard many of our systems are stretched thin. When we don't adequately fund ReachUp, the demand for other services rise. It increases the burden on families, needing to know who to contact to meet each specific need, self-identifying poverty repetitively, and filling out multiple applications. It also transfers the state's responsibility to under-resourced community organizations. Some examples of the community resources that attempt to make up for this policy choice include food pantries, principal funds at schools, diaper banks, special funds at parent-child centers, toy drives, coat drives, boot drives, car seat programs, and the list goes on and on. Just kind of want to share a little bit about how sort of our choice to apply a rateable reduction also impacts the ReachUp program itself. The new engagement model that you've heard and that you've worked hard to establish within last year's policy improvements will only work well if families have the financial resources to participate. The number of families participating in the post-secondary education program has been steadily decreasing over the last decade. We have heard from parents who are interested in post-secondary education opportunities but cannot make it work with their current family demands. Again, I brought some more stories for that, but I can can send them after today or talk to you individually after if there's not time. So as a committee, you have many opportunities in front of you. Voices would like to respectfully make a few recommendations. Pass H94 as written and look for opportunities to sunset the rateable reduction as soon as possible. This will show a commitment to meeting the program's goals and its statutory purpose. It will be critical to ensuring that the report created is implemented with the urgency that it deserves. In many ways, I see H94 as an opportunity to offer a partnership between the budget that starts in the governor's office and the budget that you're working on right now to reconcile and to create the structure to have a fully funded Reach Up program from the beginning. We also recommend that you prioritize funding Reach Up in the 2024 budget. In addition to the financial opportunities, the structural changes that can be made, new language within the budget should not be understated. Committing to using updated figures to determine cash assistance would set the program up for success. So we'll skip over this because you've already heard a lot of these pieces. Just want to acknowledge that the buying power is steadily decreasing for Reach Up. There's some examples of that. And I want to conclude by just acknowledging our growing and thriving Reach Up coalition, and once again offer my gratitude for the work that you are doing to create a more equitable safety net for Vermont.
Thank you. And you did hear the testimony from the department in terms of the amount of work that they're currently doing and the request to move the date out. Thoughts on that?
I did. And I do appreciate the incredible amount of work that the department is doing. So I appreciate that question. I do not see this particular piece of the work as a big lift. I really see it as simple as a chart that shows this is our current benefit, this is the current rateable reduction that we offer, and this is the impact on families. If we're going to move from a 50% rateable reduction to a 0%, here are some ways we can do it. And it could be, broken up 20% each year. They can come up with a figure that makes sense for them. I do think that the number of families eligible will increase, although other states have not seen that play out quite as dramatically as one might anticipate. But again, the increase would be families of 3 making less than $17,000 a year. And so I don't think it'll be very difficult to sort of figure out, based on our economic data, sort of how many families that is, and they could create a range, right? So if we had the current number of caseloads, it would look like this. If we had this percentage of increase in caseloads, this is what it would look like. So I don't see this piece as being a big labor lift, but I do think that the beauty of the bill is not just in the chart, right? It's in us kind of shifting the structure so that the legislature receives the budget eventually with a fully funded Reach Up program. I'm not currently aware of sort of any other part of the budget where we apply a 50% automatic reduction at the beginning of the process. And I think in many ways that will make the job of the legislature a little bit less demanding when you're at the end trying to shore up all the budgets, when you know that this program is coming without an unfunded mandate of half.
So, okay, thank you. Appreciate that. And of course, when one is looking for a report that will remove the rateable reduction, then there's a thought that it's actually going to happen. So that after a report, there's also conversation about what can happen. So thank you for your testimony.
Thank you.
All right. So we'll come back to this bill another day. There's a lot of information embedded in that one little bill, and also the decision about the date. I think the date is probably the big decision. Okay, thank you. I promised the committee a 5-minute break, and I'm going to adhere to that. So we're going to come back just before quarter after, and we'll be picking up